Okay, welcome everyone to the Essential Substance Abuse Skills webinars today. I'm Kate Tran, the National American Indian and Alaska Native ATTC, and today we have Robert Foley speaking on HIV, STDs, and family and community roles in prevention. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that previous education alcohol and drug certification exams. Please check out our other upcoming webinars in this series, as well as our American Indian and Alaska Native Behavioral Health series, which takes place on the first Wednesday of each month. I will note, though, that next month we've made a slight change due to some scheduling conflicts and to avoid Veterans Day. We've actually had to change our schedule a couple times, and we are now holding that webinar on November 12th, which is a Thursday. So that is still going to be our spirituality and behavioral health webinar. We're actually expanding it in recognition of Native American Heritage Month. So it is going to now be a 2 to 3 hour webinar on that day. It'll still start at the same time as our regularly scheduled webinar series. If you have questions about that, contact me, and we'll make sure you have the links to register for that one as well. Our center is a NADAC certified educational provider, and CEHs are available on request for a $15 fee. A request form is available for download in the Files pod in the webinar screen, and we'll also be sending this form in a follow-up email to all who attended. Immediately following today's webinar, you'll be redirected to our GPRA evaluation. GPRA stands for the Government Performance and Results Act, and SAMHSA, our funder, asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so if you have questions about the presentation or about Adobe Connect system, please use the Q&A pod by typing them in the field at the bottom. We will address questions at appropriate points during the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's speaker is Robert Foley. Mr. Foley has worked in various aspects of the prevention field for the past 12 years, including positions in drug and alcohol use, HIV and STI, and intimate partner violence, being named by POZ Magazine as one of America's most influential AIDS activists in 2010. Mr. Foley is currently the Acting Director of Public Health Programs and Policy at the National Indian Health Board, which was previously the President and CEO of the National Native American AIDS Prevention Center. While there, he oversaw projects that provided programmatic development training and capacity building to mobilize Native communities to engage in HIV prevention efforts. Mr. Foley has served on numerous governmental consultations to provide guidance on the implementation of USA's National HIV/AIDS Strategy, including the consultation on government agency implementation plans, LGBT populations, and state involvement in implementation. So we were so excited to have Mr. Foley here with us today. It's going to be a really informative session, so welcome everyone, and thanks for joining us, and I'll pass things over to Mr. Foley at this time.
Thank you so much, Kate. I appreciate that introduction, and I would also like to mirror her. Welcome to everybody. I really appreciate you taking your time and your busy schedule to join us today for this webinar. On the screen are the goals and objectives we hope to accomplish today. of which there are 5. We'll be reviewing some of the basics of HIV as well as HIV prevention. We'll be spending just a little bit of time on sexually transmitted infections, or STIs, and we'll be explaining the core components of communicable disease prevention, talk about factors and risk, and then talk about what this means to substance abuse treatment and service providers. This has been a webinar that I've had the honor of partnering with American Indian Alaska Native ATTC to do a couple times in the past, and we continue to refine it to make sure that we're meeting the needs of the community and the population. So you'll see that on today's webinar, we will talk a little bit about HIV and just a minute or two about sexually transmitted infections, and we're going to be spending the bulk of our time together talking about prevention, prevention strategies, prevention theories, and prevention trends. As many are seeking to achieve some of the core competencies, we've listed 2, 105 and 106, that this particular webinar will seek to address. And so let's start with HIV and AIDS. Where are we in what is continuing to be called an HIV epidemic? Currently, there are about 1.2 million people in the United States living with HIV, and that is through the end of 2012. There's still almost 13% of people that are living with HIV that don't actually know it. And based upon some new numbers and some new models the CDC has been running for the past 3 or 4 years, we're looking at about 50,000 new HIV infections every year. Right. And the thought is, over the past 25 years, I should say longer, over the past 35 years, that we've been battling this particular epidemic, we see the numbers increase every year. And the thought of that is actually statistical, epidemiological, and actually begins to become common sense if you understand it. We have new treatments, new medicines these days that are allowing people to live longer. And so we are inherently increasing the pool of infectiousness when we have more people living with HIV and AIDS. So especially in certain communities where more people are living with HIV and AIDS, there's an inherent increase in risk. And so we thank goodness that we have people prolonging lives, but it just means we need to adjust our prevention strategies to ensure that people are not unknowingly transmitting the infection. When we look at the statistics, you'll see by region, and this is diagnosis, okay, so the majority of diagnoses are happening in the South. The HIV epidemic within the last 8 years has a strong foothold in the American South, and that's where we're seeing the most new infections. And you'll see the other regions are fairly evenly split, with the Northeast, especially with the larger urban areas in the Northeast, having slightly more than the West and the Midwest. When we look at HIV diagnosis by race and ethnicity, the African American community has almost 50% of new diagnoses annually. And that also tends to make sense, knowing that most of the new diagnoses are in the South, where we have large African American communities. Second, by number, is the white Caucasian with a little over 13,000, and then just under 10,000 is the Hispanic Latino community. The American Indian Alaska Native population accounts for 228 new diagnoses annually, and I believe these stats are from the year 2011, although the stats don't change all that much. When you look at the relative impact and the proportion and rate of new diagnoses, then African Americans still have the highest rate of new diagnoses. Hispanic Latino have the second. Native Hawaiians and other Pacific Islanders have the third highest rate. American Indian Alaskan Natives have the fourth highest rate. And then white Caucasian have the fifth highest rate, and then Asian American populations have the sixth highest rate of new infections. So we know that the African American community is disproportionately impacted by HIV and AIDS. And we can also see from this breakdown that men who have sex with men, or MSM, which is a more inclusive term that includes individuals who engage in homosexual behavior as well as those who identify as homosexual and engage in homosexual behaviors. So white, black, and Hispanic Latino MSM account for the vast majority of new HIV diagnoses annually. And then you'll see the color coding. The light blue color on this particular bar chart represents men, and then that brick red color represents women. And so black heterosexual women, white heterosexual women, and Hispanic Latino women are also represented on this bar chart. The routes of transmission, I think we all know at this point that it is sex without a barrier, or condomless sex, which is we're calling it these days, not necessarily unprotected sex, but condomless sex. That's the most common way that HIV is transmitted. The second most common is through the use of injection equipment for those who inject drugs. And just, when we talk about injecting drugs, that's not always illicit drugs. There's also hormone injection, steroid injection, and even those who might be injecting other medicines for hepatitis C or diabetes, such as insulin. So we need to look at all the populations that are using needles and injection equipment. We're fortunate to say the occupational exposure, the exposure that happens through your jobs, especially for medical providers, has almost been eliminated in the United States, as well as transmission through contaminated blood products, such as through a blood transfusion. Parent-to-child transmission, including prenatal and through breastfeeding, is also almost eliminated in the United States. Within the American Indian and Alaskan Native community, we may see 1 or 2 transmission from mother to child in a year. But even when that happens, it's rare. So we've done a lot of things right in the United States. HIV is the virus. It stands for human immunodeficiency virus that leads to AIDS, which is a syndrome, and AIDS stands for the acquired immune deficiency syndrome. Once a person is infected with HIV, they enter what is called an acute infection. An acute infection lasts anywhere from days to 3 or 4 weeks. During that time, there's going to be a rapid replication of the HIV virus in the body, which will produce an immune response that looks like the flu. People will have sore throat, a rash, might be experiencing some night sweats, fever, and kind of general malaise and fatigue. For this reason, people who have been infected with HIV often misdiagnose themselves with just having a cold or just feeling a little under the weather, especially when after 3 or 4 days these symptoms can disappear. At which point a person goes into what's called asymptomatic infection, which can last anywhere from 2 to 12 to 13, 15 years, a long time. During that time, the HIV virus continues to replicate in the body at a very, very rapid rate. And while that is happening, that virus is attacking the CD4 T cells within the body, right, which is a very specific white blood cell. And so as you have your viral load increasing, your number of viruses increasing, your white blood cell count is decreasing. And it's that juxtaposition that will ultimately lead to a person being diagnosed with AIDS. The idea of quote-unquote full-blown AIDS is an outdated concept. Although we'll still see that term from time to time, it's not something we use very often anymore. We do talk about an AIDS diagnosis rather than being diagnosed with quote-unquote full-blown AIDS, especially since there's no such thing as half-blown AIDS. An AIDS diagnosis can only be delivered by a doctor, and it occurs when an individual's CD4 T cell count drops below 200, or if they've been diagnosed with certain opportunistic infections, which are those infections that occur in a person who is severely immunocompromised. Once a person is diagnosed with AIDS, that doesn't mean that their CD4 cell count won't go back up. It also doesn't mean that they're going to die soon. It simply means that they reach a certain level in their body where the HIV virus, at least at that time, was winning. I think that's an easy way to put it. Once a person's been diagnosed with AIDS, that diagnosis is not reversed or taken away. A lot of what's been driving the discussion around HIV treatment and prevention these days is the treatment cascade. This came out of a very large longitudinal research study that involved the Denver Department of Public Health. And you'll hear this called many different things: the HIV cascade, the treatment cascade, the Garner cascade, as it was named after one of the researchers, Dr. Ed Garner. What it says that within a given number of individuals, there might be 1.1 million people living with HIV. Out of that body, 874,000 will know it. Okay, so only a certain percentage will actually know about their HIV infection status. Out of that group, 655,000 will actually be linked to care. So that is actively referred to an HIV medical provider, someone who can prescribe medicines and monitor disease progression. Of that group, and there's a significant drop off here, only 437,000 will be retained in care. That is to say that they will continue to see their doctor on a regular basis, continue to receive their tests, monitor their CD4 count and their viral load. Of that, almost 350,000 will need HIV treatment or antiretroviral therapy, or ART. And then of course those who need them, only 262 will get them, and of those who get them, only 209 will actually be adherent or achieve an undetectable viral load. This treatment cascade, from top to bottom, is important because it begins to identify the gaps in our HIV prevention and treatment system. And it's within these gaps, literally what is between the lines, that tells the service provision community where we need to begin to focus efforts. In this gap here, in this first gap, obviously we're talking about being able to achieve 100% of those who have HIV knowing it. So we need to increase testing efforts. Within the second gap here, we're talking about what can we do with those people who have HIV to ensure that they have access, ready and easy access, to qualified and competent HIV service providers. What can we do then, once they're in care, to make sure they stay in care? And then once they're in care, staying in care, what can we do to make sure that they have access to HIV medicines? And once they have them, what can we do to make sure that they stay on them? Recent and powerful research has shown that an undetectable viral load, or so people who remain on their HIV medicines and can take them consistently and continually, will achieve a viral load that isn't readily detectable through blood tests. The virus is still there, but it's just reached such a low level that it's not easily detectable. All right, and research has shown that those with undetectable loads stand a significantly decreased chance of transmitting the virus to another person. So this has become our end goal more than ever, is achieving undetectable viral loads. This treatment cascade has led to the implementation of high impact prevention. And we've been implementing high impact prevention for just about 6 or 7 years now. High impact prevention was spearheaded by the Centers for Disease Control and Prevention, the CDC. And there are about 5 or 6 tenets of high impact prevention. But some of the most important ones include, what can we do to ensure that the services we are providing will reach the most people possible in the most cost-effective manner? That's not going to be a big surprise to anybody on the line. Really, that's just a fancy way of saying what can we do to do more, to reach more for less, that costs less, right? And that's been a common trend, I think, economically in recent years. But to achieve that, we're talking about integrating programs. How can we integrate our HIV testing programs with drug screening programs? What can we do to work within systems that already exist, such as the jails and schools? And what can we do to reach those individuals who are at the highest risk? We looked at HIV statistics already. We know geographically where the risk exists. And we know certain races or ethnicities have displayed a higher risk, particularly the African American, Hispanic, Latino, and indigenous populations. And we also know that people engaging in certain behaviors are at higher risk. Men who have sex with men are included in that. People who inject drugs are included in that. Partners of people who inject drugs, as well as those who are trading sex for money or drugs or other resources. So how can we create, expand, and scale up these programs to reach those highest risk populations? There's also been a push to utilize programs with scientific merit, those that have been quote unquote based upon evidence, which has led to a focus on more biomedical interventions and less behavioral interventions. High impact preventions also reintroduce a focus on certain old school prevention strategies, so we see a throwback to the days of a focus on HIV testing, as well as condom distribution and outreach. Outreach, of course, is that strategy to move out into the community to work with high-risk populations where they are. And there have been some creation of some new strategies, and we've tweaked some old ones. We know that not all evidence-based interventions work exactly as we want them to, and if they do, they might be kind of expensive, right? So we're focusing evidence-based interventions on those that can reach the highest risk populations and those that can reach larger numbers of people. Right. There's been an increased focus on biomedical interventions, which I'm going to talk about a little bit later, and of course getting people into treatment. Getting them into treatment, getting them on HIV meds, and getting them to achieve undetectable viral load. With the focus on HIV testing, there's been expansion of testing opportunities, and there have been grants that have gone out to what used to be called non-traditional settings, but very much have become standard settings now for HIV testing. We see testings going on in emergency rooms and emergency departments, dental offices, pharmacies, as well as outreach testings like at bars or on the street, at powwows, at health fairs, things of that nature. There are, of course, some challenges in testing in those settings outside of a clinic or a hospital. Confidentiality settings, what do you do, or are you prepared to work with someone immediately should they have a reactive test or a positive test? And when you're out there, when you're in the field doing these tests, you often have limited time to actually work with a person. So these are some barriers and some challenges that logistically and systematically agencies and organizations need to work through, need to prepare, and need to write into their standard operating procedures and/or standing orders for conducting HIV tests. All regardless, it has become a prevention emphasis, and we see just a ramp up of testing. Now, I mentioned the focus in high impact prevention on getting people into HIV treatment. And I mentioned earlier the value added of antiretroviral therapy, or ART. It does reduce the viral load significantly, decreases the likelihood of transmission of the virus, should an exposure occur. And a person not living with the virus can take HIV meds to actually protect themselves from infection should an exposure occur. And that is what we call pre-exposure prophylaxis, or PrEP, P-R-E-P. And that is a new prevention method, a new biomedical method that, again, I'll talk about in just a little bit. But it is a person living with HIV, not living with HIV, so an HIV negative individual will actually take, as a prescription, HIV medicines. And as of right now, there's really one most popular prescription, and that's it's 1 pill a day. A person can take 1 pill a day, and it provides significant protective biomedical barriers against HIV should an exposure occur. And so that's another prevention method that is, it's actually been around since 2010 is when the research was approved, and the buzz research was published, and the buzz started to begin about PrEP. Admittedly, there are still some barriers with companies, private providers, and practitioners who are confused why people might be asking for HIV medicines when they're not living with HIV. And there's also some internal debate about insurance companies, and should insurance companies be paying for PrEP even if an individual is not of a high-risk community or not admitting to engaging in high-risk behaviors. Right? But the value of antiretroviral therapy, and it's being called treatment as prevention, is kind of the buzz term, for individuals living with HIV to reduce their viral load, and for individuals not living with HIV to serve as a protective biomedical shield, if you will. Linkage to care, we talked about this when we looked at the cascade. This is the structured and purposeful process of moving an individual from the very minute they receive an HIV diagnosis into stable and continuous care, or at least what you would hope would be stable and continuous care. That includes some personal counseling components with an individual, right, to talk with them about the barriers and the fears, the misconceptions they may have about the virus, living with the virus, and what HIV treatment may look like. When I have worked with individuals in this area, I often tell them that really it's an identity shift, because you're talking to a person who is now going to be who is diagnosed with a chronic disease. In their eyes, they may see it as a fatal disease, right? And they're now worried about not just the stigma and the communication that they need to do personally, but they're transitioning to becoming a lifelong patient. So there's some significant barriers that people encounter psychologically once they've been diagnosed with HIV. And talking to them about going to go see a doctor and continuing to see a doctor is extremely stressful. There are also some administrative and logistical barriers, such as, is there a qualified provider in the area close by? And that includes rural facilities, Indian Health Service, and tribal facilities. Is there someone who is trained or certified to monitor HIV disease and who understands the treatment regimens and can diagnose and monitor regimens? And of course, there's the ability to pay. Within the Indian Health Service, HIV care is provided for, and those medications are on the IHS formulary. Of course, with the advent of the Affordable Care Act, there are increased opportunities for individuals with insurance to access that care. But oftentimes people need help navigating those systems and those barriers. All right. And that can happen through the support of a case manager or a social worker, as well as medical staff. And then there are environmental barriers, such as transportation, and geography is always a concern. It's important during this linkage to care component that you work with an individual to evaluate all their available care options. And again, there's the insurance and affordability options. Linkage to care programs, especially very structured programs, aren't required for all individuals. Some people may come in for an HIV test and receive a reactive test and anticipate that they were going to be receiving such. And so they may not need as much counseling or preparatory work. But others may need multiple sessions before they're ready actually to go see a doctor. All right. So a linkage to care program, LTC program, should be available, right? And providers, regardless of the settings in which they're engaged, that are conducting HIV tests should be prepared to at least begin the discussion of linkage to care with all individuals who receive a reactive test. So that was a smash course in HIV 101. And I said we were going to spend but just a minute on sexually transmitted infections. I've just listed 9 STIs that are up here, And I've categorized them into bacterial, parasitic, and viral sexually transmitted infections. Bacterial STIs include gonorrhea, chlamydia, and syphilis. These three are extremely common. In the United States, chlamydia is the most common out of the three, although within the last 15 years, we've seen 2 spikes in syphilis. And so there's continuous concern, especially in urban areas and amongst MSM, about the increase in syphilis. And then in the Great Plains, we also saw a syphilis outbreak earlier this year. So syphilis, while it never achieves the numbers that chlamydia and gonorrhea do, continues to be a concern. What's important to note about bacterial infections is that they are curable with antibiotics. With gonorrhea, there's some concern about certain strains that have become antibiotic resistant. However, the doctors and researchers continue to formulate new treatments that are keeping antibacterial resistance at bay, thank goodness. So what is important with bacterial infections is the testing and the treatment component, right? Because it is curable, so it's just a matter of ensuring that testing opportunities are available for all 3 of these tests, and that treatment opportunities are available for all people and their partners who test positive. Then, of course, you need to ensure, and this is oftentimes where STI prevention becomes tricky, ensure that individuals complete that treatment without re-engaging in high-risk behavior or condomless sex. Parasitic infections include pubic lice or crabs and scabies. These are also curable. And curable is not exactly the right word for a parasite, but I wanted to use parallel language here. It is quite easy and simple to remove the parasite, especially since the parasite, they tend to be superficial, topical. Scabies can burrow just a little bit into the skin, but with antiparasitics and topical creams and just some monitoring, within a matter of a week or so, you can eliminate crabs and scabies. Viral STIs include HPV, the human papillomavirus, HIV, herpes, and hepatitis. I just listed A, B, and C, although of course there are more hepatitis strains. HPV, the human papillomavirus, we've heard a lot about with the advent of the HPV vaccine in recent years. The human papillomavirus has a lot of different strains. Some of the strains lead to genital warts, and some of the strains also lead to a mutation in cells that can lead to cervical or anal cancer, which is why HPV is and has become a huge concern. HPV is not curable, but it is treatable. And to note about HPV, of course, it is preventable now with vaccines for certain strains. Okay, not all strains have a vaccine, but those strains that have been shown to ultimately lead to cancerous mutations do have a vaccine. And that vaccine is approved for both young men and young women now. I should say young women and young men now. We talked about HIV. Here's herpes. Herpes is not curable. There is no vaccine for herpes, but it is treatable. They're antivirals. And then, of course, hepatitis A, B, and C. A and B is preventable with vaccines, and hepatitis C is preventable through, as all of these are, behavioral changes. We tend to say that viral STIs are treatable but not necessarily curable. I want to talk a little bit about hepatitis C. Hepatitis C, it can be asymptomatic, or there could be a mild clinical presentation of symptoms once a person becomes infected with hepatitis C. A doctor can test for, I should say a service provider can test for hepatitis C, and it can be detected within about 1 to 3 weeks after exposure and infection. But the average time for a person to actually seroconvert is 8 to 9 weeks. Okay, so it's a fairly long seroconversion, longer than HIV. Chronic hepatitis C infection develops in 70 to 85% of those who are infected. All right. So in a small number of people, they will actually clear the hepatitis C virus themselves. In 70 to 85%, it will become a chronic infection for them. And of those, 60 to 70% will develop acute and active liver disease. And most infected individuals remain unaware of their infection because they're not presenting any kind of symptoms that would cause them to think that they were sick or would drive them to a doctor to receive a test. There have been heightened recommendations around hepatitis C testing as well as treatment in the last 5 years. And so I should say with a fair amount of pride that is now recommended by the Preventative Services Task Force and endorsed by several federal operating divisions that everybody that was born in 1945 or later should receive a hepatitis C test at least once in their life. So really what we're saying is that there's a focus on baby boomers. All right, there's a focus on testing baby boomers at this point right now. Once a person tests reactive or positive for hepatitis C, that's not to say that a doctor is going to immediately recommend medication. You know, there was some what we're still kind of calling traditional treatment, which was a very intense regimen of injections accompanied by some pills, and that took up to 48 weeks. Happy to say that within the last 2 years, there have been five new regimens that have been prescribed and approved by the FDA that are all oral, can exhibit almost no side effects, and are exhibiting 92 or higher, 92 to 100% effect in achieving a sustained serologic response, a viral response or SVR. And basically we're saying that's an effective cure. The HCV is not completely eliminated, but it's depleted at such a level that it's being called effectively cured. The problem with these treatments, they are extremely expensive and there are access issues. Oh, and I'm sorry, there are 6 new regimens, and I've listed them here. So it's 91 to 100% sustained SVR, and you can see the different combinations of medicine. In 2003, 2013, 2014, we saw sofosbuvir, and literally this last summer we saw the last one approved, which is Tecnivir. It is important to note because a lot of people are now actively asking for these medicines, especially those that might have previously been diagnosed with hepatitis C and avoided treatment because the traditional treatment was so intense, painful, and debilitating. Hepatitis C co-infection, so those individuals living with hepatitis C and HIV, is a serious concern because the treatments, especially the traditional treatments for hepatitis C, they interact with each other and they're contraindicated sometimes for each other. So I'm not going to spend a lot of time on this, other than to say it's important for an individual living with either HIV or hepatitis C to receive a test for hepatitis C or HIV, right? Receive a test for the other infection. And if both come back positive, then to consult with a doctor on a treatment regimen that is going to be effective. And it may be a matter of undergoing hepatitis C treatment and withholding HIV treatment in the short term until an effective cure is sustained, and then beginning HIV treatment. Just because there is one treatment could lead to increased viremia for the other treatment, and one treatment might contraindicate the medication regimen for the other. So it's important that a person consults with their doctor if they are living with HIV and hepatitis C. When we talk about prevention opportunities for hepatitis, it is hepatitis A and B, vaccine, 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 vaccine. Right, that's the easiest way to prevent is to ensure that even if should a person be exposed, infection will not occur. With hepatitis C, we need to continue screening, look at the recommendations, Be sure to implement reminders in electronic health records that will trigger reminders to service providers that a person needs a hepatitis C test, should they be of a certain age or engage in certain behaviors. We need to be able to counsel those individuals around their behaviors, refer them, and that includes a referral to substance use treatment, and then talk to them about behavior change interventions. I mentioned that behavior change is our primary prevention opportunity for hepatitis C at this point, and that includes how people are injecting, their thoughts about injecting drugs or alcohol. Actually, we have talked to some people who have been injecting alcohol directly into their bloodstreams. Right. And so we need to be prepared to talk to people about their level of risk and their acceptability about their risk behaviors. Once we have that information, we can begin to counsel them on ways, strategies, and methods that will be realistic for them to lower that risk. So we have just a couple case studies. And I'd like everybody to take a second as I put this up here. I'll read it out loud for those who are walking around their offices and aren't sitting at their computer. I will read this out loud. The tribe was hosting a community diabetes screening and education event. Tribal members were having their blood drawn during the course of the day by a medical professional. Again, this is for diabetes. At the end of the day, you notice far fewer disposed of needles in the sharps containers. You ask staff why, and one responds that he was just reusing the same needle to draw from multiple people. You immediately shut down the operation and start to worry about the implications. So my question for you, and I'll ask you to use the chat box just to write down your quick responses and thoughts on this, is have multiple people been potentially exposed to HIV? All right, and so we're talking about HIV exposure. You have an individual that has been drawing blood throughout the day and admits to reusing some needles to draw from multiple people. Has there been an HIV exposure? So I see 3 people have put up their responses. 4 all saying yes. A couple more people are going to be putting up some responses. Yes. Improper disposal of needles. Yes. Yep, absolutely. Exposure is imminent. Yep. And I have to be honest, I know that this seems pretty rudimentary, doesn't it? The answer is yes. There has been potential exposure to HIV for those that were subjected to a reused needle. And I'm sure some people on the line are thinking, well, this is a no-brainer, this is pretty simple. But honestly, this is a real-life story, and it's a real-life story that happened last year. So this isn't from the 90s, this isn't from the 80s, this is from last year, when a medical provider on a reservation was reusing needles for a public screening event. And so it boggles my mind that in this day and age this can happen, and not even when we're talking about just HIV, when this can lead to so many other exposures for diseases, and is clearly in violation of universal precautions. But it is still happening. I'm happy to say that the operation was shut down. People were contacted immediately, brought in for HIV and hepatitis C testing, and everybody came back negative. All right, so there was a potential exposure, but we learned that even if exposure did happen, there was no resulting infection. Let's do something similar. Brooke has been consistently using heroin for about 15 years. Sometimes she shares her equipment with other users, and sometimes she doesn't. Her friend Nikki shot up first the other day, but only used half of what was in the barrel. She handed off to Brooke, and Brooke shot the rest of the heroin. Does Brooke have a possible exposure to hepatitis C? Okay, people are putting in yes, and I will let Claire know that I do see your question, Claire, and I'll take note of that and be sure to answer that. Okay, looks like everybody's been answering yes, 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 exclamation point. All right, and the answer is, of course, yes. She does have a possible exposure to hepatitis C. Hepatitis C actually thrives inside a syringe and inside the barrel of injection equipment and can last actually for quite a long time inside. Just so you know, HIV comparatively cannot. It's a fairly weak virus, does not live well outside of the body, even inside injection equipment. And it should be said that Brooke has been exposed potentially only if Nikki is living with hepatitis C, and only if some of Nikki's blood was drawn back into the particular syringe. And that's something we're going to talk about in a little bit, the differences between exposure and in transmission and infection. So I would like to just real briefly talk to Clara's question, which says, can you please provide a guideline about the specific follow-up once the patient has maintained a negative test after?
Well, nothing is
And this is important. The CDC does have new guidelines for HCV testing. It talks about when testing should occur and when retesting should occur after effective cure, sustained serologic viral response has been achieved. And so I actually don't have the specific date with me, Claire, and the timeline for when retesting should occur. But I will say, actually, if during the course of the webinar, I can actually pull that up and provide you the link to the CDC's testing guidelines. The CDC does and is responsible for creating those testing guidelines, and they've taken a leadership role in that as well. So we're about halfway through the scheduled time, and I want to spend the rest of our time now talking about prevention particularly. But I wanted to take a break and just checking with Kate and see if we have any questions or anything that had come up via the chat box that I might have missed. And Claire, I just put the link up to the CDC's testing guidelines into the box, and so that is for everybody to look at and to peruse. It's a pretty detailed response. And also the U.S. Preventative Services Task Force has also a set of HCV testing guidelines that would be important to read. So we're going to talk a bit about some theory here. And this might be a review for some, hopefully it's new for some others. We're going to talk about levels of prevention and methods of prevention. And where, as substance use treatment providers, you can begin to intervene in HIV, STD, and HCV prevention. There are 4 levels of prevention. You know, back in the day, there were really only 3 that we talked about: primary, secondary, tertiary. Now we've had quaternary prevention. Primary prevention refers to methods to avoid the occurrence of disease, either through eliminating the disease agents themselves or increasing resistance to disease. A simple example does include immunizations. I like to think of primary prevention as focusing on preventing the condition from ever taking hold. So any activities you engage in that would prevent exposure is primary prevention. So immunization and vaccination, using condoms, using new injection equipment, and we've learned now that HIV treatment is primary prevention, especially when we talk about treatment in the form of pre-exposure prophylaxis or PrEP. Secondary prevention refers to methods to detect or address an existing disease prior to the appearance of any kind of symptoms. So some simple examples include like the treatment of hypertension, right? We know that if we treat people for high blood pressure, we're going to be able to prevent cardiovascular disease. Right. This also includes all of the screenings that we do for all of the diseases. If we can identify people before they know it, obviously before they know, but before they have any symptoms, we can potentially reverse the disease, cure the disease, or treat it before it becomes detrimental. Expedited partner therapy is the provision of STD medicine and treatment to a person that they can then take home and give to their partners. Right? And so expedited partner therapy seeks to treat 2 people when only 1 person receives the test. Tertiary prevention is the method to reduce negative impacts of symptomatic disease, such as disability or death, through active rehabilitation or treatment. And this is really when we're talking about HIV, STI, and HCV treatment. We're working to improve the quality of life and the biological and physiological health of individuals that are already living with a condition or a virus or a disease or a diagnosis. And then quaternary prevention is avoiding costly or excessive interventions into the health system. So keeping people healthy so that they don't need to be hospitalized, so that they don't need to be on medication long term, if that can be avoided, of course. So that's making sure that the HIV treatment that's prescribed is the best treatment possible and the most appropriate for their strain of HIV and for their levels of viral load and CD4 counts, as well as other conditions they may be living with. And case management also is quaternary prevention, I believe. When you're working with individuals to make sure that they have housing, to make sure that they have access to food, then you're going to be strengthening them biologically as well, right? So addressing a lot of the social determinants of health that a case manager has the opportunity to address. Now, when we talk about the level of intervention, right, that's a little bit different. And intervention refers to all of those activities that we do to operationalize one of these 4 areas. So you can think of an intervention as those things that appear on your screen on the left, right? HIV treatment, using condoms, using new injection equipment. All of those things that we do to promote those behaviors are interventions, right? It's what we do to operationalize a level of prevention. So I'm going to ask you an idea, and I'm going to ask you a question. I'm going to ask you to write your responses back into that chat box. But what would you do to promote the idea of using condoms with your clients, patients, and community members? What would you do to promote the idea of using condoms with your folks. Think about it. If somebody came into your office, for a one-on-one counseling session, and you learned that they were not using condoms, what kind of conversations, or what might you talk to them about to promote the idea of them using condoms? And you can be brief.
Sorry, everyone. We seem to have lost Mr. Foley for a moment. So let me get him back into position, and I think he may have to reconnect his microphone. But while we wait for him to get connected, I'll just keep continuing reading the responses that people have submitted. So Megan says, I would talk about the risks of not doing, educate on medical consequences. Anna says, when it comes up, some have informed that they have already taken tests and not even considering re-exposure, so discussion and education is key. Gloria says, provide education on exposure and provide a safe environment to discuss the reasoning behind this decision, and provide safe zone to ask or obtain free condoms. Clara says, explore lifestyle, risk involved, and barriers to protect self, including religious and cultural beliefs. Kimberly says, learning the reason why not and coming up with compromises that might lead to a more stable and long-term behavioral changes. And Rosita says, educate, and what are the risks for not using a condom?
Thank you so much. Kate, can you hear me?
Yeah, yep, that sounds good. Thanks.
All right, thank you so much. And so what I'm beginning to see is that in this particular situation, there's a series of different interventions that people would employ in this setting, particularly education. We heard a lot about actually educating and providing factual information. We also heard a lot around conducting a risk assessment and then doing one-on-one risk reduction counseling, right? When we talk about analogy of a hard hat, talk about the risks of not doing it, educate on consequences. We're talking about one-on-one risk reduction counseling. Right, so both education and risk reduction counseling are interventions, all right, and they're common interventions we use when we work one-on-one with individuals. There's no right or wrong answer to this question, of course, because I think as people began to point out, you need to explore and understand why that particular individual does not want to use condoms. Right? Some people actually did talk about condom availability, which is another intervention. So it may be a matter of they want to use condoms, but they just can't get to them, or they can't afford them. Another might be a matter, as Anna mentioned, that they've tested, they are informed already, and they don't feel like they're at risk. Another might be they have no plans of having sex, for another 13 years of their life. They want to be abstinent. So you need to understand the individual circumstances a person is presenting with and provide them information, education, and sage advice and guidance that's best for their circumstances. It's important to note that interventions are the opportunity to directly connect with individuals, communities, or systems. In this example, we're talking about individual level intervention. You can also engage at the community systems level as well. To understand what is happening to create or perpetuate risk, and then you use these interventions to eliminate, reduce, or mediate the risk. Interventions always try and change something. They result in some level of change. The change can be individual, like a person walks away and says, yes, I absolutely want to use condoms now. Or an individual can walk away and say, you know what, I'm going to go home and I'm going to talk to my partner about them shooting up heroin. I can't stop them from doing it, but I can stop them from doing it in front of me. I can stop them from using old equipment, right? Or you can go and say, you know what, I'm going to vote for somebody in the next election that believes it's okay to distribute condoms in the jail systems. Right? And so then you begin to explore a more structural or political change. So we have these interventions that seek to make change, and they operate on different levels. We have individual level interventions, group level, community, and structural level interventions. Individual and group level interventions seek to change individual behaviors. Community level changes norms that guide individual behaviors. And the structural level interventions look at the policies and the systems and the social structures that are in place that either feed into the norms, but always and ultimately lead to individual risk behaviors. So which is the best approach? Do you focus on the individual? Do you focus on the community? Do you look at the structural or systems? It's hard to say. All right. You need to understand what's appropriate both for your community and for the issue. Always look at the science and realize what's effective. We know that syringe service programs have been proven effective as a structural level intervention. We know that treatment as prevention has been effective as an individual level prevention. And we know that there are various opportunities such as social marketing campaigns that have been shown effective to change community norms. Obviously, you need to do what you can afford, right? And looking at that cost more than ever drives our decisions around programming. There are some individual level interventions that are expensive but effective. It costs a lot of money to pay one person to work with one person, right? And in the course of a day, you might be able to see 8 or 9 people, but that's an expensive employee, right? Even if those interventions are effective. And so having a question and answer, cost effectiveness and cost analysis benefit for all of these programs is important, especially as you make the case to administrators. When we talk about prevention and programming, we need to talk about where is it most effective to intervene and how can we intervene. We need to understand that a high-risk incident, such as unprotected sex, doesn't always lead to exposure. All right? Doesn't always lead to the release of a virus. Right? And exposure doesn't always lead to transmission. Just because someone might have been exposed doesn't mean the virus is actually transmitted from one person to another. And just because transmission occurs doesn't mean infection takes place. All right? And then, of course, once infection takes place, doesn't always mean that person or individual is going to continue to spread it. But we need to ask ourselves, where do we intervene in this space here? How do we make sure that exposure doesn't lead to transmission, transmission doesn't lead to infection, and infection doesn't lead to a person continuing to spread HIV or hepatitis C or other STIs? So understanding the risk and exposure tells us where we intervene in that process. It also tells us what method is going to be most effective for us. For example, do we want to focus on behavioral interventions or do we focus on biomedical interventions? And that's where we begin to talk about putting all of this theory into practice. And you, as substance use treatment providers and service providers, have the opportunity to do HIV, hepatitis, and STI prevention through your individual or community practice. It doesn't really make a difference. And I know that substance use providers have so much on their plates already. And so it's not to ask you to do one more thing, but it's understanding that you have an increased opportunity to do so much with these particular diseases. You already have experience with behavior change professionally. You engage with high-risk clients daily. And you have experience and know what it's like to instill a sense of accomplishment, self-improvement, and the value of health seeking within your clients. And obviously, you have a vested interest in reducing the number of injection drug use occurrences and HIV risk. That may happen while people are under the influence. So I'm going to move past that. And I'm not going to talk about syndemics because I think we all understand mental health, substance use, HIV, and other infectious diseases overlap. There's significant overlap in the risk factors, the risk causes for all of these diseases, conditions, and we see many people exhibiting comorbidities and dual diagnoses. So that's a given, and that's become a reality. So the question is, how, where? The current prevention foci is either, when we talk about HIV and STI and hepatitis C, it's either behavioral or biomedical. Behavioral talks about what can we do to get people to change their actual behaviors. Biomedical interventions talk about how can we intervene in the disease process physiologically, right, to prevent disease progression and to prevent the spread of any of the diseases. Behavioral interventions are individual, group, and community, right? It tends to focus on psychosocial components or individual components of behavior as people exhibit them. Whereas biomedical interventions, again, talk about the biology, the pathology of particular virus or bacteria, and HIV treatment or prevention as treatment as prevention is a biomedical intervention. Pre-exposure prophylaxis, which we talked about, is a biomedical intervention. A biomedical intervention that's been around for a long time, since the mid-'80s, is, at least for HIV, is PEP, post-exposure prophylaxis, and we see that in the medical field. If a person has been exposed to HIV, even if they don't know they have it, because you can't test for HIV that quickly after an exposure, they can go on HIV medicines to prevent the transmission or exposure from leading to infection. Right? So you can go on HIV meds, take them for 30 days, receive an HIV test, and hopefully those medicines will have prevented an infection. So that's post-exposure prophylaxis, or PEP. We also have microbicides, which are foams, gels, and jellies that contain a certain percentage of HIV medicines, and those can be applied to the vagina. There still hasn't been good research about the anal use of microbicides, but those serve as a protective barrier, and the research is very, very promising on those, and ongoing. And then even circumcision is now classified as a biomedical intervention for men, because research has shown that circumcised men stand a decreased chance of transmitting or being infected with HIV, and that's where the research is primarily focused on circumcision around HIV. What's interesting to think about is a lot of the interventions that we're promoting for HIV, STD, and Hep C prevention are actually a combination of both behavioral and biomedical in nature. So the idea of expedited partner therapy, or giving somebody who, for example, tests positive for chlamydia in the clinic, giving them medication that they can take home and give to their partner for chlamydia, or chlamydia and gonorrhea generally, since we preemptively treat both. And the idea behind that is biomedical in nature. Let's treat this so there's reinfection does not incur. But however, the behavioral component includes a partner feeling comfortable going home and talking to their other partner about their test, their diagnosis, and the treatment. All right. So it precludes a certain level of comfort and skill in communicating about these complex and sensitive issues. HIV testing, it's one thing to receive a test, it's another thing for an individual to feel comfortable getting an HIV test, to feel comfortable talking to their service provider about their behaviors in an open and honest way. Pre-exposure prophylaxis, it's one thing to go and get a prescription for HIV medicine, it's another thing to self-admit that you might need pre-exposure prophylaxis. You might need to go on PrEP because you're engaging in high-risk behaviors, and then actually go in and get it. And the same thing with medication adherence. It is one thing to be prescribed HIV medicines, even to be retained in care, but it's completely another to get up at the same time every single day and take a pill. Right? There's a lot of behavioral components to being sure that people take their medicine at the right time and correctly every day. And so this is where we see this blending. Previously, behavioral interventions firmly sat within the realm of the nonprofit field, right? And biomedical interventions sat firmly in the medical field. And now we're seeing and acknowledging the blending of both. And so we see nonprofit service providers, HIV testers, case managers beginning to talk more and more about these biomedical interventions, and we see doctors, nurses, service providers, and community health representatives and community health aides talking more and more about behavioral interventions, right? And we're seeing behavioral interventions being adapted and adopted for clinics and by clinics in a more brief and abbreviated version so that clinicians have the time to implement them. The biomedical interventions are so important these days. One, because they've been shown to be so effective, right, in reducing viral load and preventing STD co-infection and reinfection, that they've become one of the most cost-effective forms of prevention. So within either the biomedical or the behavioral realm, we have to look at the social and behavioral risk factors, right, that contribute to the underlying risk in the first place. And this is where we begin to talk about the community and the communal aspect of risk. Right? At the individual level, we know that partners influence our behaviors, sometimes control our behaviors. Right? We know that social networks exhibit influence on what we do, what we buy into. Right. Social networks reinforce and proliferate community norms that influence our behaviors. Individual substance use, especially if there's a history of substance use or exposure to substance use, we know that that contributes to risk. At the communal or societal level, we have rampant poverty, homelessness, and lack of access to resources. Those resources that might provide that valuable education or information, right? Or those resources that might provide the HIV testing and treatment, or those resources that might address these other issues like poverty, homelessness, unemployment, education, safe space. Right? So without these valuable resources to address these other issues, we know that people stand a higher likelihood of engaging in high-risk behavior. And then there are physical factors as well. Geography continues to be a barrier, even in urban areas where resources might be readily available. If a person can't get to them, they simply can't get to them. They might just as well be 200 miles away. Right. So when we look at this from a social ecological perspective, we have an individual that exhibits knowledge, attitude, skills. We can continue to build upon that list. Self-efficacy, values, perception of risk, all the above. We tend to do our best work when we focus on the individual level. That's where historically we've seen some of our biggest successes, is when we focus on the individual behavior. Because especially when we talk about communicable disease, it's the individual behaviors that do transmit the viruses and the bacteria. Right? So ultimately, we seek to acknowledge what those individual behaviors are and those the level of knowledge, lack of knowledge, the attitudes, perspectives, skills, lack of skills, and self-efficacy that affect those behaviors. And we can understand them and explore them by looking at the interpersonal level, like social networks, friends, families, the school, especially when we're dealing with youth, obviously when we're dealing with youth. What's the school environment? What's the school philosophy around education and discussing especially sensitive issues? Schools play a primary role in socializing youth these days. Schools tend to reflect what the norms of the community are. So what are the norms of the community? What are those cultural values within that community? And then those norms are often influenced by our public policy. You can look at these concentric rings, or kind of the layers within the onion, if you will, on a micro level. You can take this and you can put it within a community, or you can take it on a macro level. You can put it within the whole country or within a whole population. You can even, sometimes you can do it globally, although it's hard to say that there are certain schools, norms, and public policy that affect the global community. But understanding how each of these layers impacts an individual's risk and ultimately their behaviors tells us how we need to be shaping our prevention approaches. We can begin, not necessarily begin, but we can include working with families. Right. Families are the primary vehicle for socialization. Socialization is the communication about and dissemination and propagation of community norms. Right. So how do families begin to communicate about what is right and what is wrong? How do they begin to communicate and reinforce social expectations of what a person should or should not be doing? Right. So when we talk about prevention and a family's role in prevention, and sometimes this comes across, I've got to admit, just a little fake, like, what? You want families to do that? But the point is, families already do these things. Families inherently are talking about these, operationalizing their own family values. It's a matter of taking a step back, acknowledging it, and working with families and parents and children, right, to acknowledge it and understand how they can influence that socialization process. So in the short term, families can create a social support network. Families can reinforce that they are a support network for each other, right? And by doing so, they begin to foster a stronger framework for open and honest communication within the family. Right? Families can foster access to health care, especially if it's through the provision of an employer's insurance. So perhaps one or both of the parents is carrying insurance that they use for their family members. Right? And it's a matter of supporting, creating not just the administrative opportunity to seek out health and health care, but also saying it's important. Let's go to the dentist every 6 months. It's important to get an annual physical, right? And you create a value. Families can avoid hypocrisy. This is extremely challenging, especially when we have policies and laws that say it's okay for adults to do things and not okay for youth to do things. And rightly so, but it's often what leads to this vision of hypocrisy amongst our youth. But families can serve as role models. Adult family members and older siblings, nieces, nephews, aunties, uncles, they can all serve as role models to the younger members of the family. And families can create opportunities for dialogue. And this actually does take some practice about how to have a good dinner table conversation, or how to watch TV together and talk about what they saw on TV, or listen to the radio in the car and then talk about what they hear in the song. So these are some active things that family members can do, and family members can begin to think about how they can do. In the longer term, doing these kind of things will begin to create a communication norm, right, and an openness that it's okay to talk about personal issues and that they should be talked about. Right? It devilifies sex, and especially when we work in communities where sex is taboo, and talking about sex is taboo. Right. You can begin to explore, especially at the family level, what are the safe spaces and the safe ways to talk about sex. And you can begin to combat gender norms, that women should do this and men should do that, women should not do that, and men should not do this. All right. Because quite oftentimes those gender norms and those rigid polar ideas that we have about what's acceptable for one gender over the other contributes and feeds into risk. At the community level, communities have a responsibility to establish the resources and access to resources. And it is a community's responsibility, it is a community's government's responsibility to examine what resources are available at the community level. And if they're not readily available locally, what is being done to ensure availability. and that's for HIV and for substance use. Create social policies that emphasize health, wellness, equal access, and I should say equitable access, and disallows discrimination. Right? So that's what communities have a responsibility to do. The opportunity that present themselves to communities and community leaders are to shape the norms. All right, those social expectations around sex, drug use, risk reduction, harm reduction, and gender. Right, all of the existence of all of these norms shape how, especially youth, right, they're so susceptible, right, through that socialization process, about what youth see as acceptable around sex, around drugs, right, around teen pregnancy, around healthcare, around risk. You know, if we're teaching youth that it's okay to be risky, you should take risks, that's a good thing, then if that's what we're teaching them, that might be what they operationalize when it comes to sex, alcohol, and drugs. Communities have opportunities to encourage sexual and substance use education in schools. Each community should examine what that looks like, what's appropriate for those settings. I'm not going to say there's one size fits all here, right? But communities need to identify what opportunities exist and what's appropriate. And then creating policies around syringe service programs and safer injection facilities. This tends to be still a fairly liberal concept, but we know that safer injection sites and syringe service programs, whether they be exchange programs or even disposal programs, they do work, right? And they do lower risk, and they do lower the incidence of HIV and hepatitis C. At the systems level, we can begin to understand the community needs. And that is systematically undertaking an assessment to understand those individual behaviors that people are engaging in, right? And then take that information and align services to the community needs and the community culture. Service providers should be working hand in hand with community health aides and representatives. They should be working hand in hand with HIV nonprofits. They should be working hand in hand with their hospitals and their clinics and their public health departments and tribal health departments, all of which I guarantee in some way, shape, or form are conducting community assessments as mandated by certain accrediting bodies, as mandated by the Affordable Care Act. So these assessments are taking place, but we need to make sure that those assessments are approachable, accessible, and culturally appropriate for the community, and that information is being shared in such a way that allows service providers to actually alter and align their services to understand and address the individual behaviors, craft an intervention and prevention approach that's going to align with community needs and culture. Systems can identify those norms, and they can actually, as a community, as a system, decide which norm is potentially harmful, right? And then talk about how that norm can be changed. They can ensure access to the services. They can design and provide services through a health equity lens. Look at not just one size fits all right, but look at, one size fits best, right? So there's not an approach that's going to be best for everybody, but are you ensuring that the people who need the services the most are receiving the services? All right. I'm going to skip over that one. So however we define community, we're always susceptible to the influence of our community, medically, socially, environmentally, and we have the opportunity to impact systematically on all of those levels. So we're coming close here to the end, and I wanted to begin to wind down with one final case study. So I'm going to ask you to get ready to type some of your responses again while I read this. Chris has been hitting the gym hard and recently started to bulk up. He seems pretty moody these days and has been lashing out at team members for little to no reason. His grades are fine and hasn't experienced any recent stressors above the normal. His coach has really been happy with him on the football field. Is there anything that jumps out to you as observant service providers that might concern you? So So again, he's been hitting the gym, he's been bulking up, he's been pretty moody, lashing out. His grades are good though. Really no major stressors. And we'll say his football coach is pretty happy with how he's been performing on the field, so he's been playing pretty well. Is there anything to you that might concern you, something that you as a substance use professional would want to address? All right, I see some things starting to come in. Paul is saying steroids, question mark. Stephanie says possible testosterone use. Michael's also saying steroids. Karen's saying hitting the gym hard. Clara's saying steroids. Karen's saying this moodiness is causing her some concern. Rebecca says possible increased energy mixed with moody is a possible concern. Gloria, use of any substances. Kevin, he may be using performance-enhancing drugs. Luther agrees in saying possible steroid use. I agree with all of the above, right? His moodiness is an indicator, right? His bulking up is an indicator. There might be some performance-enhancing drugs, most likely testosterone, through the use of anabolic steroids. So now we're going to begin to peel away some of those layers. When he's asked about it, Chris says that he doesn't see a problem with his behaviors. He tells you that he is a bigger man than everybody else on his team and that they should look up to him. He calls his teammates sissies and states that he knows his father would be proud of him. He tells you that he is now the kind of man that his parents and grandparents would be proud of, that he can truly be strong now. What kind of social issues do you see at play now? And let's just look at that question. We're not going to deal with that. How can these contribute to risk for right now? But what kind of social issues do you see at play now that we have a little bit more information from Chris? So Chris says he doesn't see a problem with his moodiness or lashing out to his teammates. He's calling his teammates sissies, and he says his dad would be proud of him, and be proud of his behavior. He tells you that he's the kind of man that his parents and grandparents would be proud of. All right, so we see some potentially self-esteem issues here. This is the behavior of a person who does not have self-confidence in themselves. Karen says social issues around the parents and name-calling, self-esteem, some parental pressure. Clara also agrees that there's some self-esteem issues at play. Family dynamics, roles, cultures. I am also thinking about his development and the stage he is in. Where is his dad? Gloria poses some interesting questions here. Rosita agrees that self-esteem is an issue. So when we look at some of these social issues at play, obviously they're impacting him on the individual level, right? He has some self-esteem issues. He's experiencing some parental pressure, right? But what Gloria is getting at with family dynamics, roles, and culture, I appreciate, because these are the social issues that are impacting him, right? That's creating his thought processes that makes him feel like it's okay to call his teammates sissies, and it's okay to lash out his teammates, right? And that he should and has to be strong, right? There might be some gender issues at play here, that he may think that as a man, he needs to be aggressive, he needs to be bigger, he needs to be dominant, right? And Luther talks about family and community belief on what a man should be, and I definitely believe that that's a social issue that's at play here, right? And some of that definition is, I will guarantee, will be impacted and informed by his community and his culture, right? And all of these contribute to his conceptualization and acceptance of risk. if the community norm is to be an aggressive man, and if that's the dominant community norm, then in order to achieve that norm and to make his family and proud of him, it's acceptable for him to use steroids. It's acceptable for him to lash out at his teammates. Okay? This is why we need to look at the social pressures within the community. As substance use providers, you have the opportunity to examine these social pressures and to examine the risk in all of the assessments that you do. Include action items with any individual treatment plans that include HIV, STI, and HCV risk and testing. You have the opportunity to explore these particular, especially social and familial issues within counseling sessions. Obviously, you're prepared based upon our first case study to provide education and explore risk with individuals. You also have the opportunity to interact with Ryan White case managers that work one-on-one with people long-term living with HIV. Within a clinical setting, you also have the opportunity to do the HIV, STD, and viral hepatitis screening and tests and administer the vaccinations for HPV and hepatitis A and B. You can provide the referrals and assist with the linkage to care programs that might be necessary. You can work on medication adherence as part of your own counseling practice. And as always, in what you should be engaging in, I assume you are actually, is providing that basic HIV and STD education to your patients. At the environmental level, it's important that providers create an environment where it's okay to discuss sexual behaviors and identities, to create that safe space. And then understand how sexual behaviors and identities interplay with substance use. Serve as a conduit for information for individuals and families. Make condoms available. As was mentioned before, put that free basket of condoms out. And create and reinforce programming that makes syringes more accessible for high-risk users. And I just have a couple more slides, and then we'll take some final questions. But at the social level, substance use providers can create programs that combat community norms actively, right? Support programming that is, of course, appropriate for the culture, age, gender, and orientation of their patients. Implement cultural and wise practices. And I say implement, I don't say incorporate or integrate, but I say implement those traditional practices. Engage families in longer-term treatment plans and discuss how norms and pressure are impacting the risks people are engaging in. At the structural and systems level, deliver the required preventative services under the Affordable Care Act. Implement those widespread screenings. Engage in systematic quality improvement to understand the gaps and the deficiencies that currently exist in your service delivery model, and work towards health equity in both access and service delivery. These are a list of some of those mandatory preventative services I'm sure you're all very familiar with at this point. And I think the end message is that there's an opportunity, right? There's a common overlap between risk populations, risk factors, and risk behaviors amongst people at risk for HIV, STD, and hepatitis, as well as those at risk or engaged in using substances. So that integration and that overlap is an opportunity that we need to keep our eye on and take advantage of. We always need to be solution focused, understanding that prevention services with active drug users need to utilize a positive service delivery model, remain strengths-based regardless of who we're working with, remain mindful, be authentic in our practices, and be intent and purposeful, and understand the approaches we're using. Where are we going to attempt to intervene, and where are we going to have the most impact and make a difference? So with that, I know I went a couple minutes over, but I wanted to go ahead and turn it over to Kate and also open it up for any questions that people might have. And I do apologize that I did want to stop about 10 minutes ago for questions, so I apologize, but I appreciate the time that you provided me today to talk.
Thanks so much, Mr. Foley. That was a really excellent presentation, and yeah, we really appreciate your expertise in this area. So as he mentioned, we can, if people have questions, please submit them now. We can always respond to questions at a later date. If you wanted to email me, we can can get those questions answered as well. And while we're waiting, in case any other questions do come in, oh, thank you. We got Mr. Foley's email address is available on the screen right now. So please feel free to contact him if other questions arise. And I'll leave that up for a couple more minutes. And then while I remind people, we will be sending out a follow-up email address to everyone who attended and even those who registered who might not have attended. And that will include a link to the recording so you can view this presentation again. It will include a CEU request form. So if you'd like to make CEUs for today's presentation, you can submit that. And also, in case you don't make it to the survey that we will be redirecting you to, there will be a link to the survey as well, as well as some handouts of this presentation, so you can use those to review. Okay, we have a question from Rebecca. So I'm an intern and all of this is a little new for me, but I was curious if all alcohol and drug treatment places should have an HIV indicator test, or sorry, HIV indicator test.
Now you need to understand, I believe it was Rebecca, that I'm a little biased, and so I'm going to say yes. And I think it's more about including within their assessment questions and exploration of risk behaviors, high-risk behaviors, injection drug use and condomless sex included, and understanding that there are opportunities within an assessment to explore other behaviors. For example, if somebody comes in and talks about trading sex for drugs, then that's an opportunity, a flag right there and then to begin to talk about risk behaviors in condomless sex. So I think including those risk behaviors into the assessment is an easy way to go.
Wonderful. Well, it looks like that may be all the questions that we have for now. So as we mentioned, please feel free to get in touch if you have any additional questions. And I'll just remind everyone to register for our upcoming behavioral health webinar on spirituality, and that is in part of our celebration of the national celebration of Native American Heritage Month. That's taking place on Thursday, November 12th. And with that, I think I will close out. Mr. Foley, do you have any final words you wanted to share?
I just want to say thank you. I really appreciate everyone's openness and to engage and to type into the chat box and allow me to talk. So I just want to say thank you both to the ATTC and all the participants.
Wonderful. Thanks so much. And yes, thank you so much for joining us and for participating. And with that, we'll end here and hope you all have a good day.